the prenatal screening SNIPE software, PICO, over the other competitors like Siemens and Abbott. This excellent features in this software is that this software professionally expert to establish their own mom calculator formula, and it's also support to use a local data to adjust the calculation formula. So it's a very flexible, user friendly, and then it's in more features. So you can check or you can establish their own mom value on the basis of your epidemiological distribution of that disease in your region as well. So these are the two distinct features as far I receive information. So I have forward. I hope I respond to your query exactly. If you have any further query, you can ask right now, so I can give you the answers later on. Right now. Okay, thank you. So let's start with the next presentation. That's a growth hormone. So in this presentation, you can see my screen. If I ask you, you can see my screen right now. Okay, thank you. So the growth disorders, and these growth disorders are GH plus IGF-1, IGF BP-3. These are the three markers which helps to diagnose the growth related disorders. So let's start. In this presentation, we have four parts. The first part contains the background about the growth hormone, the physiology, metabolism, and then other things. And then we have to think about the different condition in which the clinical utilization of these assays and what are the SNIPE solution for the growth disorders and the growth-related disease from the Meglumi SNIPE platform and the overall worldwide distribution of growth disorders in the world. So let's start with the background. As you know that the growth hormones or insulin-like growth factors, IX is the principle of the endocrine system, which is regulating linear growth in the children's. So if you check the growth hormone or insulin-like growth factors, there are some environmental clues or the nutritional fact. Then the pituitary glands release the growth hormones, and then this growth hormones plus the insulin levels have an impact on the liver, and then the liver release the IGF, and the IGF one insulin-like growth factors converted into the insulin like growth factor binding proteins, or then the IGF again convert into the react with the target tissues and then increase the muscles and bone growth. So through this methodological process, the physiological process, that the growth hormone act like that. So if he goes to the further, so you can see that the growth hormone is basically a somatotropin, or a human growth hormone, SGH is called, and it's synthesized, stored, and secreted by the somatotrophic cells, which is the lateral rings of the anterior pituitary glands, and that can only be recognized by its receptors. So this is the structures of growth hormone. And then there's the functions that during that process that we have discussed. So let's go to the next. In this slide, that's the biological function of the growth hormones. You can see here these IGF, or like the stimulates and division and the multiplication of gonadocytes of the cartilages, and then this process that's decrease in the adipose tissues, and then also IGF also increase the bone growth and also increase the muscles mass as well. So through this lipolysis of the adipose tissues and the release of fatty acids, and then decrease glucose utilization for the most tissues, and then stimulate the synthesis of IGF-1 in the liver. And this insulin growth like factor 1 will carry out all these functions. So this is the whole process in which the stimulation, multiplication of occurs, and then it uses lipolysis of the adipose tissues and then decrease glucose utilization for the most tissues that stimulate the synthesis of IGF-1 in the liver. So if we further goes to the circadian rhythms of the growth hormones, this is basically a markedly age-related decline in the growth hormones secretion in both males and females, and loss of night times enhancement of the growth hormone secretion is seen during deep. That's in a slow wave. And the decrease in the primary due to the reduction in the growth hormone pulse amplitude. So you can see that there's a young female and the young male. There's a large pulse and a small pulse. You can see there is a small pulse. Sorry. Occurs at different nanogram concentration at pattern of secretion in different ages and in different times as well. That's called circadian rhythms. So if we talk about the influential factors which has an impact on the growth hormones, it's a control day, the meal and the fasting conditions, and the men's and women's have a different serum growth hormone response profile of having after a 30 to 60 and 120 minutes of exercise, because in exercise they have consumed their glucose and then the insulin level, hypoglycemic conditions due to which that's the growth hormone levels increases. So in addition, some other factors also have an impact on the secretions of the growth hormones, especially when you are doing an exercise at that specific age, in the growing age, and then they have a fasting condition, exercising, insulin and glucagon will also increase the growth hormone, but hyperglycemia and dihydrotestosterone will decrease it, the growth hormone factors. So if we talk about the insulin-like growth factors introduction, the IGF protein, basically a group of protein which is similar to the structures of the insulin. So you can see here, its structure is more or less like insulin, and it's also called somatomedin C, and basically it consists of 70 amino acids and molecular weight of 7649 daltons as well. It was produced in the liver mainly and will carry out its main function. And these are the two IGF circulating in the human serum, like IGF-1 and IGF-2, while the IGF-1 is basically peptide for the 70 amino acids, and IGF-2 is a peptide of 67 amino acids. IGF-1 is the growth factors after birth, and while IGF-2 play a vital role in the fetal growth. So these two insulin-like growth factors have a different roles after the birth and during the fetal development. They play a vital role for the growth and development of the bones and the muscles of fetus and the growing child. So if we talk about the biological functions, you can see here, here the IGF basically stimulate the body growth and also regulate the DNA synthesis, while the IGF also has stimulate the growth of proliferation of the cells. You can see that the brain stimulate through the growth hormone releasing hormone, then the somatostatins, and then this pituitary glands has released and then this growth hormones release, and then it's act on the liver, and then it's released the IGF-1, and this IGF-1 has to help to thymus development and function of the hematopoiesis immune cells function. Along with that, this also help to glomerular development and the functions and the integrity, and also the ovarian follicular genesis and testicular functions and then integrity. So these are all the functions of IGF-1. And then it's a reverse feedback mechanism to then convert it to somatostatin and then stop the growth hormone releasing hormone factors. And also the IGF-1 also goes to the development and the growth of the productions like bones, muscles, and connective tissues, along with the development and growth production as an anti-inflammatory and vasodilators. So these are the main functions of IGF-1 biological function in which they play a very vital role. So if you go to the more about the insulin-like growth factor binding protein 3. So the IGF-BP3 introduction is here. So it's an 6 binding protein of IGF BP 1 to 6. You can see IGPF 1, 2, 3, 4, 5, and 6. And then the low affinity of IGF binding is with the IGF BPRPS and then proteolyzed fragment and IGF 1 and 2. So you can see here they're synthesized by the liver mainly. And the predominant IGF-PP in adult serum, which is carried out approximately 75% of total IGF, which is the 1 and 2. And then the influential factors for the age, including the sexual development, nutritional hypothyroidism, diabetes mellitus, liver function, and kidney function. Along with that, the IGF-3 levels are decreased by the malnutrition and increase in the chronic renal failures. So these are the early markers of different renal failures and malnutrition condition, and it's mainly synthesized in the liver, basically. So if we more talk about the clinical application, the growth disorders, common diseases, like if we talk about growth disorders. So the growth hormones deficiency in child or adult leads to the dwarfism or AGHD. If the resistance, that's lead to the Laroon syndromes, and if it's excess in adult, it's lead to the acromegaly, and in the children, it leads to the gigantism. So this is the overall growth disorders or different diseases due to the excessive deficiency and resistance in adult and children. So let's talk about individually one by one. So let's talk about the growth hormone deficiency, GHD. So if you talk about the growth hormone deficiency, it's basically a rare disorder characterized by inadequate secretion of growth hormone from the anterior pituitary glands. So the growth hormone deficiency occurs in the childhood onset or adult onsets. In the childhood onsets, it's idiopathic, acquired, or congenital, while in adult, it's only idiopathic and acquired, it's not a congenital. So in idiopathic, no known or diagnosable cause is for this growth hormone deficiency. That's why we call them idiopathic. So if they're acquired either through the trauma, either through the infection, radiation exposure, tumor growth within the brain, that's lead to the acquired growth hormone deficiency. It's called acquired. The congenital is because due to the genetic mutation or from the structural defect in the brain may lead to the congenital growth hormone deficiencies. That's called the congenitals. If we talk about the adult growth hormone deficiency, you can see that there is idiopathic, no known or a diagnosable cause for this idiopathic or maybe acquired, often used from the pituitary tumor or trauma to the brain. That's both cases, tumor cases may lead to the acquired growth hormone deficiency testing. So if we talk about the clinical application for the growth hormone disorders, this is dwarfism's introduction. Short stature is defined as a height more than 2 standard deviation below the mean of the age. The third percentile is called dwarfisms. Like +2 standard deviation of the height is in a female, 136 and 142 in male. The average 125 and 130. If its height is more than 2 standard deviation below the mean value or average of age in less than 3 percentile is called dwarfism. So this is the definition of dwarfism. So if we go further about the dwarfism introduction. So in the dwarfism introduction, you can see that achondroplasia, this is the most common recognized and the most common form of dwarfism in human is achondroplasia, which accounts that 70% of dwarfisms and occurs in 4 to 15 of the 100,000 live birth. So the growth hormone deficiency due to this, the spondyloperitoneal dysplasia congenita, dystrophic dysplasia, pseudoachondrodysplasia. These are the different growth hormone deficiencies occurs, and the prevalence of this growth hormone deficiency is approximately estimated 1:4,000 to 1:10,000. In the male and female, it's between 3 to 4:1. So it's more in the male as compared to the female. So if we more talk about growth disorders, about acromegaly and gigantism, that's an excessive growth hormone condition. This is called gigantism. Definition is that in which a specialized characterization due to the excessive growth hormones and the growth factors that have excessive growth and height significantly above the average height, and the childhood resulting is between 2.1 to 2.7 meters. And the cause of this gigantism is characterized by the excess of the growth hormone, because the fusion of the growth plate and the overproduction of the growth hormone that bring about gigantism is virtually always caused by the pituitary growth, that's an adenoma. So incidence and symptoms, very rare, approximately 100 reported case today. So very rare gigantisms. If in a soft tissue is abnormally tall, they have a large hands and feet, they have a large prominent facial features and an enlarged tongue. The development of sexual gonads with their defective lifespan will be abnormally short. So the acromegaly, the major cause is disease due to the excessive growth hormone after the growth plates have closed. The common cause include a tumor of hyperplasia in pituitary body. If we talk about the incidence, the acromegaly affect about 6 per 100,000 people. It is most commonly diagnosed in middle age. And you can see that the normal hands are looks like that, but in acromegaly, the fingers, and then that shows that's in the middle age, shows that type of clinical symptoms. The most involved with the enlargement of the hands and the feet occurs. In addition, they also have a joint pain, thicker skin, deepening of the voice, headaches, and problem with the vision. So these are the typical example of acromegaly, and these are the other features that helps to diagnose this and other hormones. So if we talk about diagnosis from non-invasive, especially the radiological imaging systems like the clinical system that have the male with the 6 years and the male with the 8 years symptoms of these diagnoses through the X-ray, and then the bone age study also reflect that that's a growth disorder diagnosis, along with the serological testing solution, like for the acromegaly, that's in growth hormone, IGF, insulin growth-like factor binding protein 3, insulin growth-like factor 1. So these are the markers which helps to diagnose a different condition of a patient, especially the acromegaly. So if he goes to the guidelines for the growth hormone and growth hormone disease, like we recommend the use of the growth hormone to normalize age and avoid extreme shortened children and adolescents with the growth hormone disease. So the important thing about these guidelines for the growth hormones, according to the hormone research in the pediatrics, that's the clinical practice committee publication. These guidelines, they have shown that the Y does not attain a serum growth hormone level above 5 microgram and has a deficiency of at least one additional pituitary hormones or a classical imaging trials. So it's recommended to have a screening of such patient have some clinical finding of growth hormone related deficiencies or excessive. So if we talk about the growth hormone stimulation test in the growth hormone disease, we have a few options like stimulating options. If you talk about in adults, like insulin tolerance test, growth hormone-relating hormones, arginine test, the glucagon stimulation test, arginine alone test, and mesimoreline test. So these are the few examples of growth hormone stimulation test. So how the growth hormone measured through this growth hormone disease stimulation test? So in the insulin tolerance test, the growth hormone measured between 20 to 90 minutes after hypoglycemia is achieved is less than 40 milligram per deciliter. So the administration of the insulin through the intravenous and considered as the gold standard, it should be avoided in the patient with the medical history of seizures and cardiovascular pathology. So those patients are not recommended to go through the insulin intolerance test. So the GHRH, growth hormone related, that's the arginine, measured between 30 to 120 minutes. Then the intravenous administration of the arginine is given and then become unavailable in the United States in 2008. Right now, they are not using this technique for the checking of the growth hormone disease. The glucagon stimulation test. The glucagon measurement between 0 to 240 minutes, that's an intramuscular nausea and late hypoglycemia conditions are reported and observed in this glucagon stimulation test. The arginine alone test, that's a growth hormone measurement between 30 to 120 minutes, and that's an intravenous injection of the arginine alone is given. That's in nausea, headaches, and vomiting occurs. So the mesimoreline test, that's in growth hormone, measures between 30 to 90 minutes. Oral administration in a single dose. Safety profile and the diagnosis value was not yet established for the patient with the body mass index greater than 30 kg per meter square for the pediatric population. So as of today, the most common test for the growth hormone disease is insulin tolerance test and mesimoreline. And then firstly, the healthcare professional reconstitute a solution using a 1 pouch of micromelin, how they perform the test from the mesimoreline test, like they have a mesimoreline pouch of 60 milligram to every 120 milligram of water, and then a solution of 0.5 milligram per ml based on the patient weight. The appropriate volume of this mesimoreline solution is orally administrative, and the growth hormone studies perform at 4 different points, like 30 minutes, 45 minutes, 60 minutes, and 90 minutes after the stimulation. And then the adult growth hormone deficiency can be confirmed if the maximum of serum growth hormone level is less than 2.8 nanogram per ml. So this is the process in which these are the two most stimulation tests for the growth hormone disease are, as of today, the most common in the diagnosis. So if you go to if you further go to the growth hormone stimulation test in that, so there is the IGF random marker for the diagnosis of monitoring of the acromegaly. According to AAC guidelines, the American Association for the Clinical Endocrinologist, the serum IGF level has a large number of results from age and sex matches, normal values, and the random IGF values a marker for an integrated growth hormone secretion should be measured for the diagnosis and for the monitoring after therapeutic intervention. So this is the recommendation from the AAC guidelines, and the guidelines of the IGF-1 in the growth hormone disease is also suggests the measurement of the serum IgM levels as a tool to monitor the adherence and the IGF production in response to the growth hormone dose chances. So these are the guidelines. If we talk about the practical algorithms in the pediatrics endocrinology, there is a practical algorithm for the IGF binding protein 3 in growth hormone disease combined with the IGF testings. If you go here, that the auxiological characterization of the puberty staging, there are a few cases like HT velocity and then SDS age, the parental targeting heights, and then with the parental target heights, they have some values. If they are positive, then a specific treatment is required. If they are negative, IGF-1 and IGF-BP is recommended. If high, then IGF-1 resistance, bioinactive IGF-1. If normal, then BA skeletal survey or the sequencing of SHOX is required. If normal, then the syndroma or SHOX deficiency, then the growth hormone treatment is required. So if we talk about the growth hormone provocation test, that's the growth hormone peak level, they can check through that between less than 6.7, that is in the pituitary deficiency. If it's between 6.7 to 10, then the neurosecretory dysfunction, that's in growth hormone disease, then overnight growth hormone profile, it's normal, then go to the CDGP, ISS, and the other treatment for the growth hormone treatment. If the value of growth hormone peak is greater than 10 to 15 nanogram per ml, then IGF first generation test is recommended. Then its response to that, it means the neurosecretory dysfunction of growth hormone is occurs, and then the reduced response, then it's growth hormone resistance. Sensitivity goes for the IGF-1 treatment. Same like that with the height is less than 2.5 SDS standard deviation. Disappropriate, then skeletal survey, the metabolic review, the genetic review, and then they need a growth hormone treatment. So this is all the practical algorithm for the insulin growth like binding protein 3 in the growth hormone disease combined with the IGF-1 and other assays. So if we go further for the practical algorithms for IGF-B3 in the growth hormone diseases, so you can say that height for the chronological age and bone can be expressed as an standard deviation scores according to the formula. What is height SDS? The child height minus height mean for the age and SDS for the height at that age. When you use this in the formula, you have height velocity SDS. The child height velocity minus mean height velocity over the mid age over which height that was measured, and then divided by the SD for the height velocity at that age. So for example, you have a child height is 120 centimeters and mean height for the age is 160. So SD for the height is, for example, 8. So through this process, you can calculate the height SDS, and then through this height SDS, you can calculate the height velocity of SDS. So this is a formula that can be calculation for the used by the physicians to treat that. So this is practical algorithm combined with the IGF testing, then along with the TSH, urea and creatinine, ESR, CO2, CBC. Excuse me. So that can be done. So according to that, IGF and IGFPs can be used that. So what is the solution from the SNIPE platform for growth hormone disease like growth hormone, IGF-1 and IGF binding protein 3? So the first analyte that we are discussing right now, we have a growth hormone. So the growth hormone, we have a principle of sandwich technique. And we have the ABI anti-growth hormone monoclonal antibodies, and then that we have a pack size of 100 tests and 50 tests. So this is all information about the immunoassay diagnosis for the growth hormone assays. Another sandwich covalence principle, that's in second generation growth hormone. It's also then a voice cycle is performed after precipitation, magnetic particles that occurs. So if we compare the SNIPE growth hormones, which is a quantitative, with the other quantitative competitors in the market, like if we compare our second generation and first generation with the other competitors, the edge is that we have a low sample volume, we have a same quantitative analysis as compared to the others. We have a measuring range, which is equally good. And we have a calibration frequency of 28 days, 1 month on-board stability is recommended as compared to the 14 days, 7 days, and the 28 days of others. In the Beckman, they have a ultra-sensitive high growth hormones. So if you talk about the sample type, we have a both recommendation, serum and plasma, as compared to the others. We have a traceability and the time of the first results, which is most important. We have a 21 minutes in the first generation, and second generation, we have around 28 or 32, 38 minutes as a time for the second generation growth hormones. And the traceability that we have for the growth hormones SA is WHO and IBSC 98 over 574, as compared to the Siemens, which is equally good. We have a same with the Disorin, Beckman, and serums, and Roche Alexis analyzers. So if we talk about the limit of blank, limit of detection, we have an improved limit of blank and limit of detection as compared to the others. We have onboard stability of 1 month, 4 weeks as compared to the others. They have a like Roche has only the highest onboard stability is 56 days. So So if you talk about the comparison data for the growth hormones, we have a comparison with the commercially available growth hormones. One using clinical samples following concentration of nanogram per ml, and the overall regression value is 0.9763, which is an equally good. And this most probably a correlation with the Roche growth hormones. And then we have a equally good opportunity that we have equally good third generation growth hormones. So you can see here, this is the growth hormone specters. So if we talk about the second generation, we have a second generation growth hormone correlation. Excellent correlation on the basis of 51 samples ran. You can see the regression value is 1.0 and the patient value is 0.001, which shows that the second generation growth hormone is equally good as compared to the commercially available growth hormones in the market from the competitor platforms. So this is IGF-1. Insulin growth-like factors. So the insulin growth-like factors are having a sandwich chemolysis, and then they have a perform a voice cycles, and they have a 50 test and an 100 test pack size available from that platform. So if we talk about IGF second generation, this also has an available. If we compare the second generation and the first generation of SNI, Meglumia IGF versus the competitors like Roche, Siemens, and Disorin, we have an edge of sample volume. We have a very minimum sample volume of 10 microliter. We have equally good quantitative analysis from this platform. And we have a measuring range between 15 to 2000 nanogram per ml as compared to the other competitors. They have a less measuring range. So the repeat cost and the per test cost may increase if the values are exceeding their measuring range of their competitors. And we have a calibration frequency of 28 days, which is highest among the competitors of IGF-1, and we have an equally good serum and plasma sample types is recommended. Time for the first result is 42 minutes in IGF-1, and then the second generation is not available, but it's maybe a 36 or 38 minutes. And as compared to the other competitors, they have just 18 minutes. If we talk about the traceability, we have a traceability of WHO reference material and IBSC 02/254, which are the other competitors also use the same traceability material except the Siemens Simulite. So if we talk about the limit of blank and limit of detection, we have an improved limit of blank and the limit of detection along with the onboard stability of 4 weeks. So in terms of overall, IGF has a very good competitive features, which makes the distinct from the other competitors. So if we compare the IGF-1 first generation, that the comparison comparatively available with the McLumi IGF-1. So IGF-1 binding protein 3, this is an assay that we have. We have a second generation assay, both kits. If we compare the both IGF binding protein 3 with the Roche, Siemens, and other competitors, we find that we are equally good in terms of quantitative analysis. They are all quantitative analysis. We have a minimal sample volume, and we have a measuring range is microgram per ml. So the unit conversion gives, when you convert it into the nanogram per ml, it's in an equally good measuring range. The calibration frequency is 7 days, and the sample type is serum in both IGF binding protein for the serum and plasma as well. In the traceability about the interference internal reference, we have internal reference only the Siemens 7 and WHO NIBSC 93/560 is a reference material used for the traceability of IGF protein 3 in McLumi as compared to the McLumi. If we talk about the limit of blank and limit of detection, you can see that we have an improved limit of blank and limit of detection in terms of value. It's maybe in around 5 nanogram per ml, and the 10 microgram per ml is the limit of detection. If we talk about the stability on the board, it's in a 4 weeks on board stability as compared to 28 days with the other competitors. So these are the comparison of IGF binding protein first generation with the commercially available IGFP, which is an equally good with the regression value of 0.99. And this is then the second generation IGF binding protein, which shows you the regression value of 0.97 with the p-value of less than 0.001, and on the basis of clinical samples of 57 different patients. If we talk about the marketing point of view, the SNIDE is the only company who provide a very comprehensive menu for the growth hormone disease related. So we have a growth hormone, we have insulin growth factors type 1, IGF binding protein 3. So the Roche is the only competitors in this growth hormones factors, while the Siemens is also have a challenge of having a same solution not from a single instrument platform, while the Beckman Diasorin are missing some growth hormones menu. So we have a broad menu as of today. We have 236 analytes available from the McLumi platforms. So this is the highest number of platforms, not only the highest number of analytes. We have the world fastest immunoassay analyzers, which is a McLumi X8. This is 600 tests per hour throughput. So we are as an emerging leader in the immunoassay diagnostic market with these comprehensive menu, not only for the growth hormone, for the neural tube disorders, and then genetical abnormalities and other parameters. So why SNIDE? The most important thing about the SNIDE is we are given a very comprehensive menu. If you have our analyzers within the lab for any other parameter which are not available on the automatic ELISA systems, we can give you the quicker results, or we can give you the best cost-effective analytes, because we are providing not only the calibration controls, but we have the broad menu. You can perform most of the tests on our profile, to give the quality results from the McLumi platform. So we have a different combinations of growth hormones like GH, IGF-1, IGFP, which meet the different customers' requirement. In some countries, the growth hormone and IGF are enough parameters for the growth hormone disorders. In some countries, they have utilizing IGF, growth hormone, and IGF binding protein 3 for that. If you talk about the broadest reagent menu, which includes more than 166 kinds of parameters, We have these menu. That's why we recommend we have the most analyte in the world as of today in the immunoassay market, and we have a fastest analyzers from the Meglumi platform for the solution of small lab to the medium size to the high throughput lab. So if you have any question, you can ask. Otherwise, we have to go for next presentation. So for this presentation, it is highly recommended by the team leaders. No recording and no pictures is allowed for the HE4 introduction. Thank you. Excuse me. So the HE4 introduction, if we talk about the HE4, in this presentation, we have a three-part. The first part contains the background, the ovarian cancers, and the marketing strategy for that. So you know that HE4 is basically a human epididymis protein. Let me open the... So it's a human epididymis protein is a secreted and a glycoside protein that is overexpressed by the serous and the endometritis US and the part of the previously WFDC family of protein. So this is then a protein which is secreted by the glycosides protein that is overexpressed. And basically, if you talk about the VAPS is basically a 4 disulfide code domains. Two, that's a gene encoding HE4. So this is basically a gene which coding HE4. It's located on the 21 chromosomes. So it's basically a segmented frequency amplified in the many cancers, and then normally it's not real. So if we go for further, so if we go about the what is HE4? So the human epididymis protein 4 was first identified in the epithelials of the distal epididymis and originally predicted to be a protease inhibitors involved in sperm maturation. So you can see that here. The HE4 has shown to have a great potential for the clinical use as a diagnosis and prognosis marker in the ovarian cancer, especially the epithelials. So in addition, this epididymis, which is an HE4, is also strongly expressed in the normal human trachea, the salivary glands, the lungs, the prostate, the pituitary gland, thyroids, and the kidney. So these are the key organs that through which the addition of vitamins also strongly expressed in these areas. So basically, HE4 has not only used for the diagnostic tools, also for the prognosis markers in some cancers, especially the ovarian cancers and then. So if we go to the ovarian cancers, so what is ovarian cancers? Basically, ovarian cancer is a type of cancer begins in the ovaries. So you can see that these are the ovaries, right? And these are the fallopian tubes. And this is called the uterus. That's the cervix and the vaginal openings. So this is the type of cancer that begins in the ovaries. So when the ovarian cancer found in its early stage, basically treatment works best. So earlier the detection, the earlier will gives you the most rate of survival. So the early stage ovarian cancer, really cause any symptoms. That's a typical challenge in the ovarian cancers. So, what are the signs and symptoms of the ovarian cancers? Some abnormal blotting or the swelling, which is sometimes it's a mild if its signs and symptoms are comes, and a quick feeling full when eating, weight loss, discomfort in the pelvis area, changes in the bowel habits such as constipation and the frequent need to urination, and then the what are the risk factors on which age, that's a middle age or older age, and then some if someone has an heredity issue of a carcinoma. Geno variation is also one of the major risk factor for the ovarian cancers. Have a breast, uterine, and colorectal cancer history, have an endometriosis, and then never give birth or have a trouble getting pregnancy are the major risk factor of ovarian cancers. So through this risk factors, signs and symptoms, the ovarian cancers detection at the early stage gives you the more beneficials, and the survival rate is more in terms of percentage as compared to the later stage. So if we classify the ovarian cancer in two types, so we have a different types like so if we talk about the ovarians, so if we talk about the ovarian cancer types, we have three types of tumors. The ovarian cancer is uncontrolled growth with the woman ovary. There are three types of cancers. One is called the epithelial tumor, the germ cell tumor, and the stromal tumors. So if we talk about the epithelial, this is an ovary that's an epithelial layers, and then epithelial cell tumors occurs here. If the germ cells tumors occurs, this is the germ cells tumor, and this is germ cells. And if the stromal tumors is occurred, this is the stroma, and you can see the stroma cells tumors is occurred. So this is mature follicles, and then this is all released from the ovary. So in ovarian cancer, it's an uncontrolled growth of cells within the woman's ovary, and then the epithelial tumor is majority in ovarian tumors, and the less than 2% is belongs to the germ cells tumors, and only the 1% of ovarian tumors belong to the stromal tumors. So if we talk about more, the ovarian cancers International Federation of Gynecology and Obstetric Staging. So they generally classify into stage 1, 2, 3, and 4. So according to the FIGO, International Federation for Gynae and Obstetrics, these classification is stage 1 is the tumor confirmed to the ovary, or stage 2 belongs to the tumor involve one or both ovaries with pelvis extension or a primary peritoneal cancer. The stage 3 belongs to the tumor involve one or both ovaries with cytologically and histologically confirmed spread to the peritoneal outside the pelvis and a metastasis to the retroperitoneal lymph nodes. The stage 4 is the distinct metastasis excluding peritoneal metastasis. The survival rate from 0 to 100% is at highest at stage 1 and the lowest at stage 4. So if we classify the stage 1, they have a further classification of stage 1 cancer in the one ovary is called 1A. The stage 1B cancer in the both ovary. In stage 1C cancer is the ovary and on the surface of the one ovary. Okay, so this is the different further classification of different stages. If stage 2, the stage 2C cancer cells also In the fluid of the abdominal, if the bowel is include the stage 2B cancer has been spread to the bowel or the bladder, and in the stage 3 cancers, they have a stage 3 cancer cells are in the lining of the abdominal only seen under a microscope, and then stage 3C they have a cancer is in the lymph nodes. So the stage 3B tumors of the 2 centimeters smaller are in the lining of the abdomen. So according to the guidelines here from the stage 1, 2, and 3 and 4, these are classified. If we talk about the stage 4, which show the distinct metastasis, excluding peritoneal metastasis, there in the stage 4, cancers has a spread to the other organs as well. So the ovary and the womb also not only involve also the distinct metastasis stage. So this is more dangerous. So if we talk about more the cancers, ovarian cancers, we have to go to the further ovarian cancer Federal International for Gynecology. So according to the World Ovarian Cancer Coalition, the Every Woman Studies profiles that the FIGO stage at diagnosis stage 1, the 5-year survival rate of the epithelial ovarian cancers in USA is 90%, for the stage 2 is 70%, for the stage 3 is 39%, and for stage 4 is the lowest as a 17%. So it is accepted that both 1 and 5-year survival rate for the ovarian cancers are very much determined by the stage at which it is diagnosed. So the early the detection or the early stage detection will help them to have a more relative survival age. So if we talk about the epidemiological distribution of ovarian cancers, according to the World Health Organization, International Agency for the Research on Cancer 2018 data overall all age, the Russian markets, and then Asian some markets, and then some regions from the Middle East and Africa's, and then the North America's regions are at high fronts. And this is ovarian cancer is the one of the fifth most common cause of cancer death in the woman, and the epithelial ovarian cancers is the most common type of ovarian cancer, which almost 85 to 90% of the ovarian cancers. So this is one of the next challenge for the world to overcome this ovarian cancers in the woman, because it's the fifth most cause of the cancer death in the world. So what are the signs and symptoms of ovarian cancers? The typical signs and symptoms include the feeling that need to urinate urgently or often, and the other is the trouble eating or feeling full quickly, or the pelvis or abdominal pain, or the bloating. So these are the typical symptoms of the ovarian cancers, and how to screen the ovarian cancer in the early stage. There is no obvious symptoms in the early stage. So the serum screening test using biomarker would be the useful aid to the ovarian cancer diagnosis, detection, and recurrence, and it means to be the monitor response to the therapy for the patient having treatment for the ovarian cancer at stage 1, 2, 3, or 4. So this is all about the ovarian cancers. So you can see here, if we go to the non-invasive procedures, like for the ovarian cancers, according to the guidelines, it's recommended. The CA-125 is recommended previously for the as per the guidelines for the American College of Obstetrics and Gynecology in 2001, and mainly rarely on the menopausal stage. The premenopausal stage, if the woman is less than 50 years old, they have to check the CA-125. If the CA-125 value is greater than 200, ascites, abdominal or distal transfer, TUV, their family history of breast and ovarian cancer, first degree relatives, and the postmenopausal stage is greater than 50 years of age. If the CA-125 is greater than 35, ascites, small nodules, and fixed pelvis mass not used, and the abdominals or the distal transfers, TUV is recommended. Family history of breast and ovarian cancers, that may lead to the diagnosis for the ovarian cancers. So if we talk about what are the more tools we can use for the ovarian cancer, so here are the performance of HE4 and CA125. So you can see here the HE4 and CA125 level increase in different FIGO stages of ovary cancers. And you can see that HE4 showing a diagnosis performance better than those of CA125. So in connection with HE4 and CA125, the ovarian cancers rule out can be done with the combination of CA125 and HE4. So the performance of HE4 and CA125, their sensitivity and specificity through this graph, you can see that the plot of human epididymis protein 4 and the carbohydrate antigen, carcinomic embryonic antigen CA125 determine the diagnosis of the ovarian cancers. The overall conclusion for this comparison between the CA125 and HE4 is that HE4 measurements seem to be superior as compared to the CA125 in terms of diagnosis performance and identification of ovarian cancers in the woman with the suspected gynecological disease. So this is high specific markers. So that's why the CA125 in conjunction with HE4 gives you the more clear picture for the ovarian cancers in such patient of gynecological diseases. So if we talk about the next presentation. So for the marketing point of view, the Meglumi H4 specification is based on a two-step sandwich method, chemiluminescence technique. Let me check. Okay. So the chemiluminescence immuno-based two-step sandwich technique we are using for the detection of HE4. And this is quantitative analysis, and the serum and plasma both are recommended, especially the dipotassium EDTA purple top tube is recommended for the plasma. We have a minimal sample volume, and we have onboard stability calibration in 7 days. We have a traceability of SNIPE internal reference substance for the traceability of HE4. We have a measuring range of 5 to 1500 picomoles per liter. We have a limit of blank detection and quantitation determination in it. We have a precision of 2.3% to 6.89% value between 21 to 132 picomoles per liter. The first results we acquired in just 31 minutes. And again, we have an edge of other competitors that we have providing a 50 test pack size along with the 100 test pack size also we are offering along with the free of cost calibrators and controls. So this is the edge of our product as compared to the other competitors in the market. If we go to the further comparison method, according to the Roche HE4 using a clinical samples gave the following correlation in terms of picomoles per liter. We have a regression value of 0.99, which shows an excellent correlation of our SNIPE Meglumi HE4 with the Roche HE4 available in the market. So if we compare the comprehensive menu, we have a very comprehensive menu. No one has this comprehensive menu for the carcinoma. Like if we talk about the Abbott, only the Abbott has this and the Roche has this menu. The Siemens do not have a comprehensive menu for these parameters, the Bachmann and the Biomedics. They are not have a comprehensive menu for this. So we have HE4 as compared to the other, the Siemens and Roche, and we are equally good in terms of results, quality, and reliability of this analyte. So if you go further for Principle-wise comparison of SNIDE HE4, you can see here we have a chemiluminescence-based technology. They have electrochemiluminescence and other have a chemiluminescence. If we talk about the qualitative analysis, we are providing a quantitative as compared to other. We are equally good in terms of quantitative analysis. We are two steps assays. Majority have a two steps assays. We have a sample type of serum and plasma. We have a just 15 microliter and 10 microliter samples. We have a test time of 31 minutes, and we have a limit of detection of 15 picomoles per liters. We have a limit of blank of 5 picomoles. And then with the measuring range, we have equally good as compared to the Roche and Abbott and the Fuji Bureau Bio. So we have a reference range for the pre-menopausal and the post-menopausal, and that's an equally value for the Roche and Abbott analyzers they have. So this is the information about the SNIDE HE4 as compared to the comparison with the other competitors. So the interpretation of the results, IFU paper according to the guidelines, if the patient, they have expected the range for the HE4 was obtaining by testing 356 healthy women in China, which is a study of 98% of apparently healthy women has an below 140. So they have 140 in this study. They have also studied for the 95 percentile of the healthy premenopausal women. They have a below 70. So according to the postmenopausal, they have a value for should be below less than 140, and the premenopausal is less than 70 picomoles per liter. So the results may be differ between the laboratories, and the variation is according to the epidemiological distribution of the population and the test method, and it's highly recommended for the laboratories to establish their own reference ranges for the HE4 as well if they want to run it in their laboratories. But then these are the studies based on a 356 apparently healthy women in China. So if we go to the solution of tumor markers from SNIDE platform, we have a very comprehensive menu. So what we have a conventional protein, ferritin, alpha feto, CA, total PSA, free PSA 125, 153, 19-9, CA 224. Along with that, a very comprehensive S100, NSC, CA72 with the ProGR, PSCA, HE24, and for the especially the breast cancer, Herceptin 2, and the PIVCA. The PIVCA is cirrhosis, liver cirrhosis markers, especially for the hepatologists. It's a very special tumor marker for that patient. So we have a different, we have a package size of 50 and 100 within just 31 minutes. We have a limit of blank, limit of detection, and limit of quantitation, which is very much important. So if we talk about the traceability, we have internal reference solution. The calibration interval is 1 week, and the minimum sample volume is 15 microliter is the aspirating volume, along with the both sample and serum and plasma sample type is recommended. And this is a quantitative analysis of He4 in the human blood and plasma and serum samples. So if we talk about more, the next slide, in the next slide, we have a comparison of SNIBE He4 versus the Roche He4. So we have an equally good because the regression value is 0.99. Let me check the chat message, but now no sound. Now the sound is okay. Hello? Yes. So the comparison data with the comparison of Meglumi He4 with the Roche He4 shows you here the evidence of having excellent correlation of 0.99% regression value of different concentration in terms of picomoles per liter. It shows you that we are equally good as compared to the Roche He4. So this is what we have achieved in He4 assays. If you go to the further, the test menu comparison, we have a comprehensive test menu as compared to the other competitors like Roche and Abbott. This Siemens has the missing part of the menu. But the SNIBE is along with the top leading brand. They have a comprehensive menu of He4, including the CA125, Cypher, NSC, and ProGRP and CA125 markers. So this is the whole menu that we have. We have more than 236 analytes globally available in the Meglumi platforms, and we have a highest throughput analyzer of 600 tests per hour. So this is an edge, biggest edge in terms of high volumes labs and the labs who wants to run a small analytes, and our single analytes can give them a solution to run these menus from our menu to acquire any testing from the SNIBE menu platform. So if we go to the comparison of SNIBE versus other competitors like Roche, Abbott, and Fujirebio, so they have a comparison that we have a quantitative analysis. Okay, so they have a two-step assays. We have a serum and plasma, both recommendation with the minimum sample volumes. And in the just 31 minutes, we give the results from the platform. And then we have a broad measuring range, which is equally good to the Roche and Abbott as well. We have a good lower side detection. Limit of blank is comparatively good. And then if you see that they have a reference interval, we have a equally same premenopausal and postmenopausal reference ranges from that. So if we compare the chemiluminescence technique, except the chemiluminescence enzymes immunoassay technique of the Fujirebio, we are equally good to the other competitors available in the market. So this is what we have in terms of quality, in terms of menu wise, and in terms of assay performance wise in apple to apple comparison with the with the other competitors. So how the interpretation of results or IFU papers gives you the evidence? According to the Chinese population, apparently healthy population data, they have calculated the 356 patient He4 values and they have found that the healthy woman who has an or at the edge below between 140 picomoles per liter. In the further study, they have found that the 95 percentile, the premenopausal women has a value of below 70 picomoles, and the postmenopausal women have an SA value of below 140. For the premenopausal, the value is 17 picomoles, and the postmenopausal, the value is 140 picomoles. But it's highly recommended according to due to the epidemiological distribution. They can you check their own population variation and the different method it is recommended to use to establish their own reference ranges. So these are the guidelines, but the manufacturers, the SNIPE has given a reference ranges on the basis of the population studies they have done in the organizations on their countries. So if we talk about the megaloma tumor markers test menu, we have a very broad menu. If you talk about the markers, conventional markers of ferritin, alpha fetoprotein, CA, total PSA, CA15-3, 125, 19-9, ovarian tumors, and then different markers. We have a brain marker that's at 100. We have a PAP, VSC50. We have a ovarian cancers markers. We have breast cancer markers. We have a hepatic cirrhosis carcinoma markers. So we have a very broad menu in terms of reliability, in terms of number of analytes, and in terms of performance-wise, because we are participating in the global proficiency testing like RICAS, ICAS, and CAP as well. So if you have any question, you can ask or you can write so we can conclude this training for that. Just give me 1 minute. So I have to take one picture. So I will see your comments, please. Okay, let me check your questions which are pending, and then we will say you. Just give me a one. Okay, so your question, which was related to the prenatal screening software, the answers are satisfied, or you need a further clarity? If you need a further clarity, you can ask me so I can respond you through my team. And important information about the prenatal screening that our free estriol SNIPE from the SNIPE platform is better than the Siemens product. It's unproven. So this is another features in our prenatal screening. And if you have any other question which is left, okay. Any calculation? No, everything is okay. So any other question you want, you can ask right now, or you can send me the question, so we can give you the response through my team in Russia. So thank you very much. Let me share with you. So if you have any question, you can ask. Otherwise, we can complete the training. So you need a more information about Precure. Maybe you can send presentation or us for us, right? So let me check. You need more information about Precure, right? I have to check, please. So there's a one question. If you have any customers who are doing a prenatal screening, why don't you go for a request for the installation of PreQ software? And if you need some training for the PreQ software, so then you can then you will learn more, because once you have a software in your screen and you have do the experiment on a few samples for the prenatal screening, then you will get a more learning on that. But I let me check with my leaders if they have any separate preparation or a separate presentation for the PICO software for the prenatal screening. Then we will share with you. Thank you. Any other question? So let me ask your name. That the question asked. Your name is Anton K, right? So I have also updated my team that Mr. Anton K wants response on this. So I will give it. Okay. Any other question? Anna, Malia, Irina, Sardiuk, any other question? No question? Okay. Have a nice day and take care of yourself, and bye bye. Okay, Anna. Thank you. Bye bye. Bye bye.